Allison Rodgers. How are you doing today?
Good. How are you?
Great. So thanks for taking the time to come on my show. I appreciate it.
Oh, it's my pleasure.
So let's get into the kind of what you do and how you got to where you're at, if you don't mind.
Sure. So I am a board certified obstetrician and gynecologist, and then I mainly do what we call reproductive endocrinology and infertility. And that was an additional board certification and fellowship. So I mainly take care of couples, women who are looking to get pregnant or who have endocrine or other issues that are causing problems with their reproductive tract, so irregular cycles, that kind of stuff. But mainly I do infertility. And I started out liking to answer questions. I'm a problem solver. I like to solve problems. And really, when you look at people with infertility, they have a problem and we have to try to figure out what's causing it and then fix it. And so I really liked the problem solving aspects of within OBGYN, all the things you can do within OBGYN of infertility. And I really find it just rewarding to be able to help people become parents.
I mean, that's something that, has been given a lot of attention the past decade, I feel like, but it's always been a massive issue where couples get together and trying to have kids. A lot of people don't have an issue with that and they have no problem and they reproduce and everything's great, but there's so many people that have an issue with this and we don't hear that much about it. So
yeah, 1 in 8 couples.
That's insane.
Right.
Well, let's get into that then. So the things that make that up, like, where do those issues start? If we're talking about, genetically, you're just not compatible. I mean, that's probably, worst case scenario, I would assume.
I don't think there's anyone who's really genetically incompatible.
Okay,
so
well, then that's something I'd love to talk about because
So sometimes people are carriers for genetic issues. Let's just throw out cystic fibrosis. So in people who have European backgrounds, about 1 in 23 people are carriers for cystic fibrosis, meaning they're not sick, maybe no one in their family's sick, but they have a 1 in 23 chance, which, is not that rare, of being a carrier. Now, if they want to have a child with someone else who's a carrier, which again isn't that rare, then they have a chance of having a baby who's sick with cystic fibrosis. So when we're talking about sort of genetically incompatible, I think it's not that they're incompatible, but they might have a chance of having an affected child with a severe disorder like cystic fibrosis. And when we think about, there's technology that we can use to help people who are in that situation have healthy children. Mm-hmm. I think when we're looking baseline at what causes infertility and where we can look, obviously it comes down to three things. We need a uterus, we need eggs, and we need sperm. And anybody can come to me single. So I see single men, single women, same-sex couples on either side, or heterosexual couples, and we still need those 3 things to make a baby: eggs, sperm, and a uterus.
Right.
And so, a lot of times we need to investigate whether people have a healthy uterus. Are there healthy eggs? Are there healthy sperm? And I think those things are things that we investigate when we're trying to help people have a family. And, I see a lot of couples where they'll come in and say, oh, it's got to be, I have irregular periods. It's got to be me. My partner doesn't want to be screened. He doesn't want to do a semen analysis.
Yeah.
But really, 40% of the time, there's issues with sperm, which is a lot. So the recommendations are really to do everything off the bat if you're getting evaluated for infertility.
Well, if we're talking about that real quick then, so so my male audience doesn't run off here, sperm issues, what were the most common issues there?
So it's really fascinating. There's a lot that can affect sperm quality. So, there's lifestyle things, which you guys all know, right? Everybody knows lifestyle stuff. Yeah. So being, overweight, drinking too much alcohol, drinking too much caffeine, using nicotine, and that's either smoking nicotine or not, marijuana, and also, diet stuff, eating the healthiest organic, non-processed diet you can will certainly help that. And then I have guys who have either jobs or hobbies where they're exposed to chemicals.
Okay.
So, I have guys who I live in Chicago, so there's a lot of guys here who are working steel mills.
Right.
And there's a lot of like fumes in the steel mills or the railroad industry. I mean, any of the, manufacturing where people are exposed to fumes, mechanics, I mean, all kinds of people who have different kinds of careers or funky hobbies, like depending on what you do, that you might be exposed to like chemical fumes from paints or whatever, that can all affect your sperm quality.
Well,
So those are some things that we think about.
What are some common ages like for men, for example, like where they start having issues with those things?
Well, it's very variable. So I have certainly, when we look at guys who have abnormal sperm, it can certainly be genetic. So there are some people who have genetic disorders that cause that. It can certainly be lifestyle. And then sometimes it's like we don't know, we don't exactly know what causes it. And then, one thing that really tips us off, if you're a guy and you're having a hard time getting an erection or ejaculating, or you feel like maybe the ejaculate is very, very low volume, like it does not much comes out, then you probably should get evaluated with some hormones to make sure there's no issues. And one of the biggest things I see is that guys are diagnosed with low T.
Yeah.
And a lot of guys have low T. It doesn't matter what age it is.
So that's something that there's never a set number there.
Well, there is, like, there are ranges of what normal is, but sometimes even guys at the low end of normal have some sexual dysfunction. Okay. So I hear a lot of times, like, it's just not as hard as it was before, or it doesn't seem like my orgasm's as strong as it was before. Right. And I always will check guys for hormones, a testosterone level, and some of the hormones that come from our pituitary gland that send the signals either to ovaries or testicles to do their job, we can get information about if there's issues either at the pituitary level or the testicle level.
So if their testosterone's low, then we're looking at not only low sex drive, but also low sperm count.
And people feel like crap.
Yeah.
Yeah. Right? Like guys who have low testosterone feel like crap. They don't have a lot of energy. They don't have a lot of sex drive. They're tired all the time. They don't feel like working out or doing anything. And I think it affects their overall sense of well-being. They just feel yucky. And a lot of guys have been living like this so long, they have no idea.
Well, there's such an insecurity on the male side as far as like, just hearing that someone's going to come to you is a big step, I feel like, because there's so much insecurity in that. Yes,
I think that part of that is just, the usual male machismo of feeling like they need to, they don't, of course, and nobody wants to let their partner down, right? Or feel like they're less of a man because they don't have good sperm. And of course, like, rationally, we know that's not what makes you a good father or a good husband or a good person. But I think emotionally, guys have a really hard time with finding out that they have major problems with their sperm. And here's the big kicker, is that if you have a low testosterone and you go to your general doctor or even some regular urologist, or if you're at the gym and taking, like, for example, recreational testosterone, and you start taking regular testosterone because it seems like it makes sense, your testosterone's low, take more testosterone, it actually turns off your ability to produce sperm. And it's so counterintuitive, but your body's like, oh, there's testosterone around, I don't have to do anything. And it literally shuts off sperm production.
It's not producing natural testosterone at that point too, right? So it's
Right. And so I see a lot of couples who they come in and they say, their guy has no sperm. And even after I take a detailed history of their medicines and stuff, I'll be like, so what you doing on the side, right? It seems like a lot of guys who take recreational testosterone or testosterone prescribed by a doctor. And sometimes they tell me, sometimes they don't, but like, I can tell based on their blood work, what's going on. And a lot of those times those guys have zero sperm. And I think that it's crazy to me because sometimes actual doctors give patients testosterone because they're trying to help them because they have low testosterone, and they don't, unless you're in the field and doing this all the time, they don't always understand that giving them testosterone will shut off their sperm production.
Right.
And even I always tell people, did you tell your doctor you're trying to get pregnant? And they say, a lot of times they'll say yes. And it's just, I think people are well-intentioned, but probably like nicely need to stay in their lane.
I was about to say that.
Yeah.
Your lane, this is what you specialize in. Well, so then what about women? Because I know that, this is just common knowledge that people throw around basically, that once you're over like 35 to 40, that's when you start being at high risk for pregnancy. Am I correct?
So that is a good point. So as we go through life, we lose eggs.
Right.
We actually, when we're born, it's downhill from there in terms of egg numbers. And once we hit about 35, 38, that number accelerates very fast. And so we're losing both quality and quantity of eggs. Most women lose the ability for their eggs to make a child somewhere around 42, 43, 44. And I think that is most women. I certainly see some women in their early mid-20s who have lost the ability to have children, and clearly that's not normal, which is why they're seeing me. But in general, most women sort of lose that ability. And as we get older, not only do we lose eggs in terms of quantity and quality, we also increase the chance of miscarriage. So not only are we having less eggs that can make a baby, but when we're getting pregnant, there's a higher chance of miscarriage. So I think about the number 40, the age 40. So at age 40, there's about a 1% chance of things like Down syndrome, and a 40% chance of miscarriage.
It's crazy.
And younger than that, it goes, the risk of miscarriage goes down. Higher than that, the risk of miscarriage goes up. But you have someone 42, 43, their risk of miscarriage is like 50% sometimes.
That's insane.
Yeah.
Well, you have so as we've, over decades, basically, we now live longer as a human race, and, over the development of technology and things like that. Have you looked at this in the past, like say 100 years ago, where fertility may have been harder starting at a younger age? Because I feel like we've gotten older and we're able to sustain healthy lifestyle longer, than we were 100 years ago.
Yeah, so there are some great studies that were done in like 60s, 70s of some cultures within the United States that were kind of like Amish,
okay.
Who like never used birth control, had as many babies as God would allow, and looked at sort of when they started, when they stopped, and when that fertility cut off. And most of those women, early 40s, were not able to have children anymore, starting sort of at that point. So from that perspective, it hasn't changed a whole lot. What has changed is that there has been a decline in the age of what we call menarche, or the start of the period. And we know that like when you start having periods is when you can first be fertile. And the reason is because our nutrition has gotten improved, right? So most of us are not starving and malnourished in United States. I mean, there's certainly a lot of people, a lot of places that are, unfortunately. And if you look at the average age where somebody gets a period in different countries, it's different. And it's not because humans are different overall. I mean, obviously there's some genetic differences and stuff, but in general, it has to do with the nourishment that people get when they're young, and also obesity. Obviously in the United States, we have a lot of obesity, and the more obese a child or a teen is, the sooner they'll get a period.
Okay, that's interesting. I wasn't aware of that. Is it just because their hormones are developing quicker because they're...
Yeah, I think part of it has to do with the fact that fat cells have some estrogen creating ability. Okay. Due to something called aromatase. And so I think it has to do with that. And typically, very, very thin people, we think about like dancers and gymnasts, have their periods delayed because they don't have enough body fat. Body fat, sort of all of our sex hormones, yeah. So testosterone, estrogen, progesterone, they're all created from cholesterol. Yeah. So, fat is important for reproduction.
Well, so let's talk about that. When you brought up obesity, that's a good point. So being that, not healthy, in a not healthy lifestyle, and that's a very broad statement. To narrow it down, basically just say that you have no medical issues at all. You're perfectly healthy in that sense, but you're overweight. What are some challenges you see with that, with your patients coming in that, whether it be the male or the female being obese, and then, counteracting that, and basically do you go with a homeopathic, path first and then go into medication, or how do you do that?
Well, I think that when we look at obesity, it's certainly a very, sensitive topic for everybody. Right. And I really try to when we look at women who are pregnant and obese, which is a definition based on BMI above 30.
Right.
We look at a lot of complications of pregnancy. And when you're in my field of trying to get patients pregnant, obviously we want them to have a healthy pregnancy. And so, whether it's high blood pressure or other things, prior cancer or whatever, we want to make sure that as going into pregnancy, which is my job, is helping them get pregnant, they're really set up to have the healthiest pregnancy possible. And when we look at obesity, it really affects things like risks of prematurity, risks of gestational hypertension, risks of other, serious gestational diabetes, serious pregnancy complications. So when we back that up and look at trying to get pregnant in and of itself, men who are obese tend to have lower sperm counts, again, because fat cells create estrogen. Estrogen can sort of counteract what their testicles are doing. And sometimes really obese men, there's so much tissue that their testicles are just too hot because their tissue's all touching each other, and the reason your testicles are outside your body is because they work best a little bit below your body temperature. And that's why when you're hot, the testicles lower because it's trying to get away from your body heat. And maybe everybody knows this, I don't know. And when you're cold, they go up, because they're cold and they need to sort of stay at this temperature, like a few degrees under body temperature. And if you can imagine a scenario where somebody is so large that and there's no space there, that it's just the testicles are sitting between their legs and skin, and they're just getting cooked, and they can't get colder than body temperature, and so that they're not producing sperm sort of as efficiently as they can be. So on the male side, obviously, there's different levels of obesity. That's pretty extreme example. But on the male side, we see that, and on the female side, we see that women who are overweight sometimes aren't able to have normal cycles, and they stop getting their period. And sometimes it's related to disorders like polycystic ovary syndrome, but other times it's not.
Well, I don't mean to cut you off real quick, but I don't want to forget this. Yeah. So I'm doing that, and because I'm real big into the health and fitness, and I also work out with a lot of people, and I've seen that on the female side to where that naturally their testosterone levels are so high because they work out so much, like for instance, like CrossFitters and stuff like that. And, they're eating healthy and everything. Their testosterone levels are so high that they just quit having a period naturally. And
it probably has more to do with their drop in percent body fat.
Okay.
As opposed to sort of a rise in testosterone. But what we see is that as you drop, and I think so there's two extremes.
Okay.
So the one extreme is very, very low body fat. That's what I was talking about, like dancers, gymnasts, and then obviously people who are training for marathons or other things. Yeah. Their body fat drops so much that their pituitary gland in their brain is like, whoa, I'm under stress. I literally don't have enough energy to feed myself, let alone a child. I'm not going to be ovulating. And that's sort of on the low side of the BMI spectrum. And then on the high side of the BMI spectrum, there can be some dysregulation in the way the pituitary talks to the ovary. And again, it's like, I'm not healthy. I'm shutting off this, the ability to make an egg right now. And so certainly being a normal weight is healthiest for everybody. But for the women who are overweight, that's where, or are stopping, and underweight, I guess, we can give them medications to help their body make the eggs. Like I said, there's a lot more than a number on a scale. Right. It has to do a lot with, of course, there's a lot of emotion and other things involved with sort of just the the BMI number. And as anybody who works out knows, if you are full of muscle, your BMI can be high. Right. and you're really healthy and fit. And it's more about sort of, what are your chances of conceiving and having a healthy pregnancy in my book? But both extremes, too much and too little body fat, can cause problems getting pregnant.
Yeah, that makes sense that you put it in that perspective now, and I'm glad I know that, because I was just thinking testosterone. I'm Neanderthal over here, so that's all I think is, like, okay, low testosterone, high testosterone.
Well, I also think there's a lot of female bodybuilders who take testosterone.
Oh yeah, and then that's a whole nother. Of course, when that happens, yes, the chances are gone at that point. So that makes sense. But I'm just talking about natural athletes, that may be doing it, as a hobby. That's they're on that that's the trend they're rolling with this year. But at the same time, they may be with their, significant other may try to be reproduced, so that would be an issue at that point. Well, what do you have so I guess you talked about putting them on medication. Is that like second option, or when they come to you, how long are we looking at? So they come to you and they say, okay, we want to get pregnant right now. I'm sure you have some kind of analysis you lay out and then say, okay, we have to do these.
Sure. Yeah, so the first thing we do is the evaluation. And like I said, it involves evaluating the uterus, usually the fallopian tubes, if there's eggs and if there's sperm. And then we look at a lot of factors. What's a patient's age? How close are they to that, sort of cliff where we think they may not have eggs? How many children do they want? So I really try to individualize care. So like if you are, 40 and you only want one child, then it's a little bit different than somebody who's 40 and wants 3 more children. Right. We sort of can have to tailor, sort of just like a financial planner is going to help you figure out sort of how to get to retirement. My job is really, what kind of family do you want to have and how do we get you there together? And then, I think that after we get that evaluation done, I really sit down with each patient and go through what the treatment options are, what I would recommend. And it really depends on what we find. So, and what the patient's goals are. I certainly have people who say, most of the time, by the time people have come to me, they've either tried on their own for a certain amount of time. The recommendation is if you're 35 or older, try for 6 months before seeing someone like me, or under 35, try for a year. So some people have tried for a year, went to their regular OBGYN, maybe got put on medicine for a couple months, and it's been maybe a year and a half, and they are like beyond frustrated and sort of beyond their tolerance limit. And they come to me and everyone's like, just upset about even having to come see someone like me. And so really it depends on the individual's goals. A lot of times we'll use medication to either help them make eggs if they're not making eggs, or help them make 2 eggs a month instead of 1, for example. And then we can kind of combine that. Sometimes patients will start with intercourse. If there's male issues, we'll start with inseminations where we put the sperm inside the uterus. And then of course we have a lot of technology that avoids the tubes. That's really like IVF. And, I have a really unique perspective because I had to go through fertility treatment to have my family.
Okay.
And it's really interesting because, so I had my first child when I was a resident, and just a general OBGYN resident, and I didn't have any trouble at all.
What age? What age were you?
28.
Okay.
Yeah, I think I delivered her right around 28. And didn't really have any issues at all. And then we waited until we were like really, really ready for number 2. And then it took a long time. And, I had to go through all of the treatments, and I had to go through all of the things. I had several pregnancy losses. And at the time it was like so emotionally difficult and felt like so devastating. Even though I had a child at home, I really felt like my family wasn't complete. And I think that it gives me a really unique perspective in taking care of couples, because I've been in their shoes.
Right.
And
the thing that speaks volume is you're not just a specialist saying, okay, we need to do these things. I've seen these cases. I've went through this. I know how you feel, and let's figure out a solution here. So that makes sense.
Yeah. And I also think that, you're talking about sort of some of the male listeners out there. I think that it's hard, no pun intended. It's difficult for a lot of male partners because, things are happening to their partner's body. And they, maybe their partner has a miscarriage, and they're grieving. That was their baby too, but they also feel like they need to be strong and support their partner through it, and can't necessarily grieve totally themselves. And I think that it's a challenging place for most guys, because it's hard for, it's difficult emotionally for them too, but they're also trying to be the support for their partner who they feel like is physically going through more than they are. And it's important to sort of recognize the struggle emotionally that guys go through also.
Well, I think it's interesting that you have an emotional, investment in it as well, because I feel like that someone who's an expertise in that field 9 times out of 10 will just be approaching it from a, analytical level.
Yeah. Yeah. It amazes me how many doctors are out there who are really good doctors, but have not the best bedside manner.
Yeah. It's just one of those things.
In all fields, actually.
Yeah. Well, now we were talking about you go to IVF. So for those who don't know what that is, it's a vitro fertilization. But I'm not. I know barely anything about it. All I know that I know people that have done this, and that's something. Can you explain that process? Because I know
Yeah.
a lot of people are against that because it's not natural or whatever it may
Hmm.
be. But I know it's a really good solution and it works well. So yeah, can you go on that?
And I think a lot of people don't like, there's a lot of misperceptions out there.
Mhm.
So, the common things I hear are, it's going to increase my risk of cancer. It's going to cause a baby with a birth defect.
Yes, dude.
Um, right. And those actually things are not true.
Right.
And so what we do is, uh, sort of put it into, the technical terms, we give a woman medication so their ovaries grow multiple eggs.
Okay.
So normally in a menstrual cycle, you grow one egg. That's it. So we give medications, and it's not very long. We give those medicines for about 10 days. So it's not like, I mean, some people have to go through multiple rounds and they talk about months and months and years, but really it's 10 days of medicine. And during that time, we will watch the eggs grow on the ovary. They come in these little sacs, these little fluid-filled sacs. We call them follicles, and we watch them grow. We measure the hormones. And when these little sacs, the follicles, become about 2 centimeters in size, which takes about 10 days, we give the woman a medicine called a trigger. And that trigger will mature the eggs inside those follicles. And 36 hours later, we do a procedure called an egg retrieval. And for the egg retrieval, we give a little sedation. I would call it twilight. And we use a small needle on our internal ultrasound probe, and we're able to collect the eggs. So it's almost like getting your blood drawn, just in your ovary. So because obviously, if you can imagine, if you're a guy, putting a needle into the testicle would be painful, same as the ovary. So we do give some sedation so they don't feel it, but the procedure takes literally 15 minutes. And the patient, wakes up, is able to get back to their usual activities the next day. We then would usually inject sperm or mix sperm with the eggs. And this is the place where treatment is very, we can really personalize treatment. So I have some couples who say, even though I'm doing IVF, I want to do things as naturally as possible. And so what we do is we will just mix the eggs and the sperm in the dish together and, let nature take its course, just like it would in the body. And,
But how does that work? If you're outside of the body, what's the is there incubation there? Like, how does that all need to be controlled? I mean,
yeah, so that's a great question. So there's different kinds of incubators we use, but we have to keep the eggs and the embryos at body temperature. So with a certain amount of oxygen and carbon dioxide. And so we keep them in incubators that sort of monitor the amount of gases inside to emulate what's happening in the fallopian tubes and in the uterus. And then also giving them being at body temperature inside the laboratory. But there's ways that we can sort of make it more natural. We let the embryos grow in the laboratory, and usually after about 5 days, we look at them and we're able to see which ones are growing healthy. They turn into what we call a blastocyst, which looks kind of like a bubble with a dot in it. And that hollow ball, the dot becomes the baby. And then the ball part becomes, the placenta and the membranes. And we're able to put that embryo back into the uterus.
Okay.
And we do that. The patient's awake. It's not painful. It's just like having a pap smear, but what I say more fun because we get to see the embryo. And it's actually, I had to go through it to have my family, and it's not so bad. I mean, I also have patients who want to do things more natural, and we do something called InvoCell, which is sort of a new technology. It's like a new tech, low tech kind of technology where we literally put eggs and sperm into this little vial. And then we put the vial into the woman's vagina. And so fertilization happens in her body. The embryos grow in this little vial in her body. And then 5 days later, we open the vial, see if there's embryos, and then we help put the embryo into the uterus. And the other thing is that, I think that people are worried about creating extra embryos and, discarding embryos, that kind of thing. And I think those are really important topics to think about and talk about. But in our lab, we don't discard anything that has the potential to make life.
Yeah.
And I think that obviously it's a very personal decisions about, you know, about the whole process. But for a lot of people, this is the only way they're going to be able to get pregnant. I mean, obviously there's other ways to family building, right? You can do embryo adoption, you can do actual adoption, you know, but I think that for a lot of people, if you have blocked tubes, if you have a really low sperm count, this is the way it's going to happen, or it's not going to happen.
What's the success rate percentage of IVF if you're like dealing with someone who can't get pregnant, and then you do that whole process, inject it back in there? What is that? Is it based on it's still based on the individual, I'm sure, but I mean, I would say that like the percentage, increase basically.
Yeah, so when we look at women who are less than 35, and we, let's say, don't do any specific genetic testing on those embryos because we have the ability to genetically test them, which a lot of people do, but a lot of people don't.
What's the reasoning for that? Like, why would they?
So, like, let's say that you and your partner were both carriers for cystic fibrosis, and you wanted to make sure you didn't have a sick child.
Right. Okay.
Also, let's say you were 40 and you wanted to prevent a baby from having Down syndrome.
Yeah.
So those are, or putting in an embryo that would lead to a miscarriage.
Gotcha.
So I think that those are sometimes reasons, but we don't necessarily need to do it in young patients. It doesn't really change our success rates unless there's a specific genetic issue or recurrent pregnancy loss or something else that we're trying to work with. But just regular sort of, let's say someone's tubes are blocked or the sperm count's really low. In those situations, then we typically will do IVF, and the chance of success is very high. I would say about 6, depends on the laboratory, right? I happen to be at an amazingly good laboratory, and a lot of it has to do with the technology. Yeah, so I'm like totally spoiled because my lab is fantastic, but it's about 65%. And 65% chance of pregnancy, we know that some of those will go on to have miscarriages. So when you look at sort of live birth rate, it's a little bit less than that, but it's pretty high.
Okay. Well, answer me this then on the IVF thing. So I've noticed a lot, and I've seen this in people that I know, that when you do the 2 eggs, then you have potential for twins, or, two, and that happens. It seems to happen a lot. I've seen it quite a few times. What's the reasoning for that? And is there a way to control that, or then?
So this is another misperception, right? So actually, when we do IVF, there are national guidelines that are released from the sort of governing society for fertility called the American Society of Reproductive Medicine. And there are national guidelines on how many embryos we're allowed to put in.
Okay.
So they've changed in the last 5 years, but if you're under 38, we're only supposed to put in 1.
Gotcha.
And if we do genetic testing, we're only supposed to do it 1 regardless of your age. So usually we're just putting in 1. Actually, you have a higher chance of twins with like more conservative treatments like Clomid or other sort of more conservative treatments that aren't IVF. IVF actually has a lower chance of getting pregnant with twins if you put in 1 embryo than if you were to get pregnant on your own. Because your chance of getting pregnant on your own with twins is about 3%. And when we put 1 embryo in, the chance of it splitting is about, in my lab anyway, it's about 1.7%. And those then turn into identical twins. So we put 1 embryo in, it can split into 2. Those end up being identical twins. And I always joke that, I put 1 embryo in, it turns into 2 babies. Like, that's divine intervention, right? Out of my hands at that point.
Well, then, I guess basically then this may be something that this misperception is basically these people are having the treatment before they get to IVF, basically, like you said, Clomid, which was an estrogen level supplement, and naturally they're just having these. Yeah.
Well, naturally but without IVF, right? But I also think that, there are people who sort of have had many failed cycles and sort of meet criteria to put in more than 1, that kind of thing. But when we look at scenarios where people have twins and what we would call higher order multiples, triplets, and more, it's not usually from IVF. It's usually from injectable medications with intercourse or insemination, that kind of stuff. Because even with Clomid, which is a tablet that women take, the chance of triplets is less than 1%. It's pretty rare.
Okay. Well, now we talked about the amount of eggs. I was unaware of that it was so slim, basically 1 per menstrual cycle. But now sperm count, I know that's something that's, the ratio is way higher to an egg. But what's your healthy sperm count, and what you would say you're like over 40? What's the diminish there?
So everyone's different, right? Some guys have a normal sperm count to the day they die. And other guys, have lower sperm counts due to all kinds of different medical issues or whatever. What I would say is sort of when we look at normal sperm, one of the main things we look at is what we call the total modal count. So how many moving sperm are in the entire ejaculate? And what we like to see is about 20 million. That is sort of a normal number of having 20 million sperm in an ejaculate.
It takes one sperm to impregnate an egg.
Right.
That's
but
insane.
One amazing sperm, because think about this. With intercourse, 99% of the sperm get left in the vagina.
Okay.
So even that's why a treatment can be so helpful, because with intercourse, only 1% of the sperm is making it even to the uterus. And then some of them are going this way and some of them are going this way. And the actual number of sperm that get to the egg is maybe a few hundred.
It's crazy.
Right. And it has to be a healthy egg.
Yeah. So you're basically an uphill battle for both. What would you say that the most devastating health issues for like a potential patient that comes to you that makes it extremely hard for this to be successful? What would you say those would be?
Well, the most common thing I see is women who don't have healthy eggs. Okay. And that's just devastating, right? We try and they're not being successful. And then they have a choice, right? And those choices include things like not pursuing having a family, things like, using donated embryos or donated eggs.
Well, how does that process work?
Yeah, so the donated embryos are usually couples who have had their family have extra embryos, don't feel comfortable ethically discarding them, and will donate them to like an adoption agency, more or less, that will help have those embryos find places to not be discarded. And those are great options for patients. Obviously, one of the nice things is that if you're a woman and you don't have eggs, but you still want to have those life experiences of carrying a pregnancy, and you still want to have that biological connection with your baby, and maybe your male partner wants to also have that biological connection. Like, just because you don't have eggs doesn't mean that they don't want to have that genetic component. We do a lot of donor egg treatment. And emotionally, that's hard because you have to kind of grieve the loss of the biological child you were hoping to have. Right. But when we look at donated eggs, you more or less can get them from a bank, like you would get sperm from a sperm bank. They're already frozen, they're ready to go. The ownership of those eggs are with the bank, so you just pay your money, they send you eggs. And then there's also fresh egg donation, where you have somebody go through an IVF cycle for you. They have their eggs removed, they're mixed with your partner's sperm. The egg donor's out of the picture. It's anonymous, so they don't know you, you don't know them, and you have parental right over those eggs.
Was there so what's the rejection rate on someone else's eggs being implanted into you? Because they're not.
I mean, it's not 100%, but success rates are very, very high, 70-75%, because they're like usually young, healthy eggs.
Okay, that's interesting too, because I didn't know how that worked as far as your body versus someone else's, and kind of like.
Yeah, it's amazing, actually.
Something. Does blood type have anything to do with this?
Nope.
Yeah.
It's so fascinating, right? Because, if you think about our immune system is very strong, and it knows who we are versus other bacteria, other viruses, other things. And when you're pregnant, you have to have literally another human with who's not you, very different DNA and all that stuff, live inside you. And so your immune system kind of calms down and allows somebody to live inside you, which is just amazing. But the same, so it doesn't, your baby is not all 100% your DNA, right? It's 50% of your DNA. And if it's 0% of your DNA, your body doesn't actually know the difference.
Okay. That's interesting too.
Yeah, that's why things like gestational carriers can be helpful also, right? Gestational carriers, if you don't have a uterus, if you're a single male or a same-sex male relationship or whatever, your uterus has been damaged, then you can use a gestational carrier to carry a pregnancy for you.
Okay, well, what about, so we talked about same-sex, like you have two women that come to you, and I'm interested to know this scenario. So what if you have two that come to you, one is planning on carrying, but then something happens and they're not able to, and the other partner, is that something that happens often?
So, a lot of times before couples, I have a large percentage of my patient population is same-sex women, and that's because they all need donor sperm, right? So they all have to usually see someone like me. And, usually they have it figured out before they see me. They, know whether they want to carry or not. And certainly egg quality is typically related to the age of the person. So sometimes if one person's a lot older versus somebody who's younger, we may want to make sure that if we're going to use the older person's eggs, that we do it right away and not waste time on that. Also in terms of uterus, sometimes women, both of them want to carry at some point. Sometimes only one of them wants to carry. So I think that usually it's sort of predetermined. But yes, there is their ability for just one person to carry if the other person's uterus. Yeah, that's amazing, right? Like they have a scenario where, in those three things you need to have a pregnancy, you need a uterus, an egg, and a sperm. Like they have two uteruses,
Right.
two places to get eggs, and they only need the sperm, which they're going to need regardless.
Right. I didn't know, like, I would think that, like, if they're coming to you at that point, I guess if they've already been vetted and know which one's the better candidate by then, I guess it's fine. But if they didn't,
sometimes they don't, though. Sometimes they don't. And then that's where I really work with each individual couple, regardless of their sexual orientation, about sort of what's best for them and how to get them to their goals.
Right. Because I feel like if someone has a mindset that I'm going to be the one that carry before they come to you, and then it must be kind of a bit hard to swallow if they realize, oh, I'm not a candidate for this other person has to, and then the entire thing has to shift, but still for the end goal of both people to have a child is, the most important thing. So
yeah, it's pretty interesting. Yeah, I mean, if you think of a possibility, it can happen. I've seen it all, I feel like.
What would be the most interesting case, of course not saying anything specific, but most interesting case you think you've seen so far that may be a milestone for you, the patients, or just something that's so moving that inspires you to talk about to other people?
Yeah, I think some of these, when we look at couples going through fertility, there's this term we call fertility patients warriors.
Yeah.
And talking about going through a journey. And I will tell you that some of my patients have been through so much treatment, so much loss. And sometimes they are so strong and they persevere. And the ones that have been trying and they persevere and they get to that goal of having the family they want to have, it is so inspiring to be able to walk with them on this journey. And, I have a lot of patients who, for example, have been trying for years, either with me or with other doctors, and then they come to me and we're able to help them be pregnant. And it's just the best feeling in the world to be able to help someone who's been through such a long journey. And you see patients, the perseverance and dedication and drive they have. It's just, it inspires me.
Yeah, it's something that you can't put a value on it or price on it, basically. Like, and then I'm sure this is a process that's not inexpensive,
It depends on where you are, and it also depends on your insurance. So I live in Illinois, and insurance in Illinois, obviously there's always loopholes and stuff, but most insurance in Illinois covers fertility.
Okay.
And that's fantastic.
Yeah.
Because it really allows, breaks my heart when the biggest thing getting in the way of patients' treatment is finances. Because, as much as I wish I could give all the services away, I still have to pay my staff and and keep the electricity on in my offices. But that is so hard when finances are the thing that prevents people from doing treatment. And we do work with grant agencies. There's a lot of sort of nonprofit grants and other opportunities to help patients. And especially being in Illinois, you can actually get on a lot of times, when the year turns, you can sometimes get on different insurance that has better benefits, but it's hard from a financial perspective. When I was going through treatment, I was living in Texas and I didn't have any fertility coverage and based on insurance, and I was living off a fellow salary, which was more or less cost of living, like just the bare bones, like horrible. They more or less, you know, it's very, very low when you're in training as a doctor. And, you know, we scraped together everything we had, you know, the money we were saving as a down payment on a house went to pay for our IVF cycle. You know, and a lot of times doctors have like samples that they get that they can donate to patients, or other patients, you know, are done with their treatment, have meds they haven't used or haven't opened, and they'll donate it to patients. So that kind of like just paying it forward for patients, we can really sort of, you know, help patients who otherwise can't afford it.
I think too that if there's people out there, especially listening, that can contribute as far as someone who's a healthy egg donor per se,
Yeah.
what would be the perfect age range for that?
Yeah, so we like to see women who are typically between, you know, usually between like 21 and 34, in that range. And usually I see these kind of women who want to donate eggs, women who are in college looking to make some extra money,
Yeah.
women who have like recently graduated from college and don't have maybe a good job yet and are looking to sort of, they're getting their career established, looking to do that. And then I also see a lot of stay-home moms that want to do something nice and also make some extra money and donate their eggs. It's an amazing gift. And they go through that process like we talked about, where you take medication for about 10 days and then have the egg retrieval. And it's an amazing gift. So usually if you're interested in becoming an egg donor, most of the bigger fertility clinics have egg donor programs. So you can just sort of call or, you know, Google, go online and see, you know, egg donor programs, and they screen you, and it's all regulated by the FDA. So
Okay.
and that really helps protect everybody's safety. So
Right.
all donors are screened for infectious diseases, and not just regular infectious diseases like they're looking for West Nile virus and all this other stuff, because really from a biological perspective, the FDA views having an egg donor very similar to, you know, getting a kidney transplant. So they do that same kind of full genetic, you know, full infectious disease panel. We also do genetic evaluation on all our egg donors, looking for things like cystic fibrosis, for example. We do fertility evaluation. We do a psychological evaluation. And, uh, and a lot of patients, you know, don't necessarily meet criteria, you know, but there are a lot of people who do, and it's an amazing gift to be able to give someone.
Yeah, I mean, I think that would be one of the best things you could do if you're someone who has healthy eggs and knows that it's going to go towards a good cause. Now, we're talking about infectious diseases. Of course, COVID's been a huge topic for the past year. And I did see where you were talking about so the risk of miscarriage, being vaccinated and stuff like that. What's your stance on that? I know there's probably not a lot of testing out yet to back all this stuff up yet, but not
Yeah,
just.
so, and they are actually starting to do vaccine trials in pregnant women, which is really great. Also, there have been about 20,000 to 30,000 pregnant women who've been vaccinated, and it seems like there's not a whole lot of red flags. I would say that if you're trying to get pregnant or pregnant and you have the opportunity to get a vaccine, the benefits of being protected outweigh the risks of the vaccine.
Right.
So we know that in pregnancy, COVID increases your risk of severe disease. And so it puts pregnant women in a higher risk for getting very sick,
Okay.
even if they're otherwise healthy. And especially if they have like one other risk factor. So asthma, obesity, like any of those other things. So I certainly would recommend patients who are trying to get pregnant and currently pregnant consider getting the vaccine. We give a lot of vaccines in pregnancy. We give
Okay.
flu shot in pregnancy. We give all kinds of vaccines in pregnancy. And like pertussis and, you know, tetanus, and like there's all kinds of things that people just don't know that we give vaccines in pregnancy if you haven't been there. And there's no reason to think this vaccine can cause any harm. And there's actually been some evidence showing that the baby actually can get some antibodies against COVID, which is fantastic.
Yeah, that's good.
So when we think about risks, and this is where every patient really needs to sort of talk to their provider, their doctor about their personal risks. There's very little risks that we know of. Obviously, there's things like a very rare chance of anaphylactic reaction, which is, really rare. But we think about things like temperature or fever. And we do know that it's not great in pregnancy to have a fever. And more with the second vaccine than the first vaccine, but a lot of people will experience some low grade, but some high grade fevers with that second vaccine. And so what the major organization, so the American College of OBGYN, the American Society of Reproductive Medicine, and the Society for Maternal Fetal Medicine, those are all the big reproductive organizations in the United States, have all recommended that you consider getting the vaccine if you're trying to get pregnant or nursing. And they really just recommend taking Tylenol, which is safe in pregnancy, around that second vaccine to keep your temperature normal. And so I think the risks are very, very low.
Well, that's another thing I was going to ask when you mentioned that. So everyone knows you're not supposed to drink, of course, consume alcohol or any narcotics while you're pregnant. Is there anything else that there may be a misconception or that people don't know? Like, I know people have a lot of opinion about being active and working out during those things, during that period. Or is there anything that people should not put in their body that people do not, that you may not know about?
Yeah, one of the things, it's not necessarily something you eat, but you're not supposed to take baths or go in hot tubs when you're pregnant, because just like the testicles don't like to be hot, babies don't like to be hot, and they have no way to cool down because they're like inside your body. And so if you submerge in hot water and your core temperature goes up, it more or less gives the baby a fever. And so you're not supposed to be going in any hot tubs or hot baths if you're supposed to be, if you could be pregnant. So that's one thing I see that a lot of people don't know. In general, minimizing caffeine, no alcohol, no nicotine, of course, no marijuana. And, I think that all the chemicals that we think about, in terms of cosmetics and hair products and cleaning supplies, all of those chemicals, have the potential, to cause harm. And so I think it's really important. Now, in the age of COVID, should you stop using bleach or, or Clorox wipes to clean up your stuff? Probably not. Obviously, you don't want to get COVID either. You want to make sure you're keeping things clean, but it is important to sort of really look at some of the chemicals that you're putting into your body, maybe not necessarily through food, but other things, and trying to make sure that you're trying to be as clean as possible.
Okay. Well, that's fair enough. Well, what about on exercise? Do you have any input on that?
So what the American College of OBGYN recommends that you can continue your usual regular exercise that you've been used to. We've all seen pictures of like pregnant women running marathons and stuff. That seems a little extreme to me. Yeah. I don't recommend people do activities that put them at risk for falling. So I'm a horseback rider. I have patients who want to horseback ride during pregnancy, and it's just important to know if you fall, you might have a miscarriage. Yeah. And so it's just not worth it, in my opinion. But certainly I have a lot of friends who are professional riders who rode quite a bit into their pregnancy, and it's a risk, it's a risk. But if you look at Robin Arzon, who is from Peloton, I don't know if you are familiar with her, but she's amazing. Yeah. And she's pregnant right now. And, I think she's gotten a lot of criticism for lifting heavy weights and running on the treadmill. And the thing is her body was doing that before she was pregnant.
That's what I was going to bring up, because I feel like there's so much criticism there. And I haven't seen, I've looked at studies before in the past, but I haven't seen where there's any that's saying that if you're an active person and you stay active, you're preventing your, risk of childbirth.
Yeah, there's really no evidence. Now, when I'm taking people through fertility treatment and their eggs are big, their ovaries are big and swollen and have a risk of twisting on themselves, do I recommend patients do low impact activities like riding a bike, like walking, and not doing like jogging or, high impact things while their ovaries are swollen? Yes, if they twist on themselves, it's an emergency. We don't want that to happen. But in general, when you're getting pregnant, like keeping up exercise is good for you. It helps you have a, healthier birth. It helps, it's a lot of strain on your body to be pregnant. It helps your body sort of keep up and bounce back faster.
There's that tell, especially I'm here in the South in Louisiana, so I probably see it more than I don't know, most people, but like where someone gets pregnant and then they use that, and I'm not a female, so I'm not going to get on like a sexist rant here at this point, because I don't have those parts, so I really have no opinion. But at the same time, I feel like that just because you get pregnant, you shouldn't stop doing everything and just lay around and not be active. I don't think that that's healthy.
Yeah, that's true. Now, sometimes there are things that doctors will advise. So there is some common things that happen in pregnancy. So sometimes people can have some bleeding in pregnancy. And then I usually tell my patients, like, you shouldn't be lifting a whole lot. You shouldn't be doing a whole lot for a short period of time, a few weeks.
Well, I mean, there's complications, of course, but
right. But in general, I think the hard part too is that, especially the first trimester, people are exhausted.
Yeah.
It's hard work growing a human, and most people need about 2 extra hours of sleep in their first trimester. And so women are just like so exhausted sometimes, they just don't have the energy to like do anything at all.
I guess if you're already active, then you're going to be more prone to stay active. But if you're not active, then becoming more active during pregnancy is probably going to be slim chance. So I get it.
But I think that moving your body is really good, for everybody, of course, even when you're pregnant. And I mean, I'll tell you, I worked out, my second one had a lot of complications, but my third one for sure. I mean, I did the elliptical the morning I got induced. And, I think that it's good to have a strong heart and strong muscles.
Yeah, I mean, overall, just being healthy in general before you even think about doing that, I would feel like would be the number one choice here.
Absolutely.
What's your biggest advice to people who are wanting to get pregnant and they're probably in the age range of, where they may have more complications? So I'd say mid-30s to early 40s. What would be your number one point of advice before they even seek out any type of medical attention?
Well, I think everyone needs to sort of listen to their body, and, for the women out there, making sure you're having regular cycles at least every 35 days. If not, you should see a doctor. Making sure, for men, that sexual function is normal. And I would recommend that, especially women 35 and older, there's no harm in getting your fertility tested. Meaning, is there sperm? What's your egg count? And that's a simple blood test, simple semen analysis. And that is easy to just say, especially people who are at higher risk. Oh, your egg count's low. Maybe you should see a fertility doctor sooner. Oh, there's some problems with the sperm. Unlikely to get pregnant on your own. I mean, there's no reason not to do that, because, then you're taking months and years, and then, your egg count is on its way down. But I think that getting some testing is always a good idea.
Well, other than that, I mean, I feel like we covered a lot here.
A lot.
My brain hurts. I want to ask you so much more stuff, but we're already at like an hour now, so I'm going to go ahead and get ready to close this thing out. But is there any final thoughts, anything you want to plug before we get out of here? I know you're really active on social.
So you can always follow me. It's dr.allison.rodgers, and it's Rodgers with a D. And I do a lot of fertility education on social media. I also think that it's really important to advocate for yourself. And if you've been trying on your own for 6 months and you're 35 and older, or a year and you're under 35, go see an OBGYN, a family practice, a fertility doctor, to get evaluated, to see if there's something going on. Because you owe it to yourself to not waste time, because ignoring the problem and waiting longer time is not necessarily going to help you get pregnant, and it's only going to cause a decline in eggs. And I will tell you, if you're not pregnant by 6 months, regardless of your age, your chance of getting pregnant per month on your own drops to only 1 to 2%.
Whoa.
Yeah. Most people are going to get pregnant in that first 6 months.
Okay. Well, that's interesting too. So if you're not getting pregnant by then, go find someone.
We're here to help you. We're not so scary.
Well, I thank you so much for your time today. And if nothing else, I guess we'll close out right here.
Thank you so much.
All right. Dr. Allison Rodgers, thank you. Everyone, please subscribe to the podcast.